Good morning everyone. Kadili lang ha, may ginaayos ko lang PowerPoint. Good morning everyone. Na babatian niyo ako? Okay lang?
Yes, Doc.
Yes, Doc.
Okay, so let's proceed with our lecture. So for the second part of our lecture, I'll discuss specific organ systems. Specific organ systems, their usual injuries and management. So this is the summary. So first we discuss the specific treatments of certain organ systems from head injuries to vascular injuries. Next, we go to surgical intensive care management, post-injury injury resuscitation, and abdominal compartment syndrome. And next is we discuss special populations, your pregnant, geriatric, and pediatric patients. So first off, we have your head injuries. So for head injuries, upon seeing the patient at the emergency room, upon assessing the patient, first yung ABCDEs, then yung assessing for um, utilizing your Glasgow Coma scale, and you're considering a possible intracerebral or possible head injury. Your first modality is CT scan if it's available, if you're considering parenchymal or extraparenchymal injury. So you do CT scan on all patients with a GCS of less than 14. So if the patient has a GCS of less than 14, patient may appear drowsy, or patient may have difficulty following commands, or the patient may doesn't have spontaneous IO feeling. So you're already suspecting a possible head injury. So you do CT scan if it's available in your center. Next, in an ideal setup, we do your ICP monitoring or intracerebral pressure monitoring, especially for patients having GCS of less than 8. So the target ICP is less than 20. So if it's above 20 millimeters mercury, so you're suspecting a possible um, um, you're suspecting a possible increase in ICP. So yung mga causes ng increased ICP, pwedeng cerebral edema from diffuse axonal injury, possible extra parenchymal hemorrhage or epidural or subdural causing mass effect causing midline shift. And if there's increased ICP, if it may be an indication for operative intervention. As I mentioned last night, if mataas yung volume, more than 20 to 30 ml, yung bleed, most likely it will cause a significant mass effect on your cerebral parenchyma, causing head injury or possible herniation. Your CPP or your cerebral perfusion pressure must be above 60 millimeters mercury. So if it is below 50 to 60 millimeters mercury, so there's a possible decreased oxygenation or perfusion of your brain parenchyma. So these are the indications for operative intervention to remove space-occupying hematomas. So based on clot volume, so yung clot volume, as I've mentioned kahapon, 20 to 30 cc, the amount of midline shift, at least 5 millimeters, the location of the clot, lalo na pag temporoparietal, or lalo na pag posterior cerebral fossa. So bakit critical yung posterior fossa? Kasi andun yung brainstem. So pag may significant amount of clot ka sa posterior cerebral fossa, it may cause brainstem herniation and the possible demise of your patient. So mas aggressive ka pag posterior fossa yung bleed. The GCS score, important din pag less than 8. So ABCDs, intubate because the patient can be apneic. Your ICP, so kung mataas yung ICP, possibly may significant amount of space-occupying hematoma that needs to be evacuated. So these are the most common, yung epidural hematoma and subdural hemorrhage, as I've discussed last night. So yung epidural hematoma, meron tinatawag na lucid interval yung patients, pero not always, hindi naman palagi. So there's loss of consciousness, then parang nagkakaroon ng brief interval of parang nagiging okay yung patient, then suddenly mag-drop yung GCS, yung sensorium. So as another thing to watch out for aside from your GCS, yung pupillary dilatation. So makapansin mo kung asan yung bleed, dun yung mapapansin yung abnormality sa pupillary dilatation or pupillary response. If there's an increased pressure sa right side ng brain, usually there's, lalo na pag may herniation, so there's compression of your oculomotor nerve. So mapapansin mo, yung right na pupil is dilated or sluggish yung response. So pag ganun, parang you will parang alam mo na most likely there's a significant amount of blood, there's a significant amount of space-occupying mass sa right hemisphere that needs to be evacuated. For post-injury care, you must maintain cerebral perfusion. So ano yung cerebral perfusion? It is at least above 20 millimeters mercury. So your cerebral perfusion pressure is the difference between your MAP and your ICP. So your target range your target range of your CPP is it must be above 50 millimeters mercury to be able to properly perfuse and oxygenate your brain parenchyma. So things to watch out for, you must avoid hypotension. So you must maintain a BP of more than at least 100 millimeters mercury SBP, avoid hypoxia, and maintain a CPP of greater than 60 millimeters mercury. Yes. Sorry for a while. So okay, let's continue. So these are the parameters that needs to be monitored for post-injury patients. Aside from these, we're also we're also sorry, we're also anticipating post-injury seizures. So most of the time, for the next 7 days, anti-seizure prophylaxis is given, usually in the form of phenytoin, and for frank seizures, diazepam is given. Next, for we have your maxillofacial injuries. For maxillofacial injuries, um, first, when you are in you in when you encounter a maxillofacial injury, the first step that you must do is control the bleeding. So nasal packing. Nasal packing usually we use it's either your operative sponge or polybag catheters. Ini-inflate mo yung balloon sa loob ng nasal cavity, posterior nasal bleeding, and oropharyngeal packing. If you're in high-end centers, prompt angioembolization is done. So what we do is yeah, it is an endoscopic procedure, and we embolize vessels that are bleeding, that are seen using your CT angiogram. For your fractures of tooth-bearing bone, antibiotic therapy prophylaxis is given. And for your cranial, you must also do your cranial nerve examination, most especially if the mastoid area or the lateral part of your face is affected, because that's where your facial nerve, and if the mastoid um, bone is in fact affected, most likely may the general nerve injury ka. So your face is divided into your upper, your mid face, and your lower face. For, for your cervical injuries, as I mentioned last night, all patients coming in the emergency room, except for penetrating neck injuries, they must be treated as having cervical injuries until proven otherwise. So, dapat naka-cervical collar, naka-immobilize yung neck. You must note for your level of injury, the presence of subluxation, extent of angulation, and level of neurological deficit, and overall condition of the patient. Yung extent of subluxation, yung extent of angulation, and the presence of fractures can be seen initially using your X-ray. But yung ideal nito is you do your thoracic CT scan for well. You do your thoracic CT scan. You can identify the level of neurologic deficit by identifying your dermatomal level. And most of the time, pag mataas yung spinal injury natin, patient may present with respiratory distress, respiratory depression because of the involvement of the phrenic nerve, lalo na pag cervical injury. And pag mataas din yung injury, most of the patients may present with neurogenic shock. So, yung presentation ng neurogenic shock, may hypotension and bradycardia yung patient. Sorry. Um, so yun. Yung on operative intervention, your deterioration, there's what are the indications for operative intervention if there's deterioration in neurologic function. So what it means, if you're having a spinal cord injury, mas hindi um, glaring yung neurological deficit, cognitive, behavioral, or sensorial deficit, but more on motor and sensory deficits in your extremities, chest and limb. So pag there's parang tumataas yung motor and sensory, quadriplegia, and until your upper extremities can no longer function. Tapos nagpa-progress na to respiratory depression and frank neurogenic shock. Then operative intervention is necessary. So another indication, and if there's fractures or dislocations with incomplete deficit, so the repair, there's aligning, if there's subluxation, if there's um, problems with angulation, or if there's fracture, what most of the time yung ginagawa is just realign them using plates and screws. For cervical injuries, for vascular cervical injuries, or penetrating injury, yung the same holds true for yung ginamit natin na algorithm kahapon for your zone 1, 2, 3, for your vascular injury na may hard signs, soft signs. It applies to these types of injuries, yung cervical injuries na may vascular injury. So pag mayroong hard signs of vascular injury, yung na-mention natin last time, pag may persistent massive hemorrhage, okay, so there's rapidly expanding hematoma, so it needs immediate operative intervention. So there's a need to do immediate next exploration. Hahanapin dapat yung vascular injury and identify the vessel involved and do immediate repair. So yung repair na ginagawa natin, pwede tayong end-to-end repair, or we can do graft interposition. So if hindi natin ma-oppose yung dalawang distal and proximal end ng vessel, you can use a PTFE graft, a artificial graft, and also we can do transposition. So we have what we call the Denver grading scale, or your Denver grading classification of your cerebrovascular injuries. So meron tayong grades 1 to 4. Grade 1 may regularity sa vessel wall lang. Yung Denver grading scale, nakikita yan sa CT angiogram, sa CT scan. So grade 1, may irregularity lang sa vessel wall. May less than 25% luminous stenosis. Pag grade 2, may thrombus. Then there's dissection and intramural hematoma with more than 25% of luminal narrowing. Grade 3, may pseudoaneurysm. And grade 4, the most severe, may vessel occlusion na. Next, for aerodigestive injuries sa cervical injury. So we have your fractures of your larynx and trachea. So fractures sa airway, sa upper airway. So there's an escape of air papunta sa subcutaneous tissue. So patients will present with cervical emphysema. Okay? So may swelling yan sa neck area na umaabot yan sa face because of the escape of air. Pero very rarely, minsan hindi siya nagpe-present with pneumothorax kasi upper airway siya. Kasi meron mediastinum that will prevent the air from going into your pleural space. Okay? So pag mataas, upper airway, subcutaneous emphysema yung presentation. After observing na merong possible upper airway injury, the next step is to document the injury by CT scan para properly identify kung saan banda yung injury and so that we can plan a repair. So common injuries include your thyroid cartilage, ruptured yung thyroglottic ligament, or disrupted yung arytenoids and vocal cords. So patients may present with hoarseness of voice, or they can if both cords are paralyzed or injured, they may present with dyspnea because of absent air entry to your lower airway. Next, going down, we have your chest injuries. So, na-discuss na natin yung chest injuries, yung most common, and the ones that needs to be prioritized. So, your open, your tension pneumothorax, your tracheobronchial fistulas, your plain chest rather. So, the most common injuries to the chest are caused by blunt or penetrating trauma. If you're considering a possible pneumo or hemothorax based on your history of physical examination and based on your chest findings, the management is the placement of your chest tube, lalo na pag hemothorax. So, na-mention ko na dati, if the chest tube drainage is more than 1.5 liters initially, or more than 300 ml every hour for the next 2 to 3 hours, then operative intervention is necessary. So you need to do open thoracotomy because most likely there's a possible lung parenchymal injury or a vascular injury that needs to be identified and repaired. So CTT will not suffice. So if you observe na marami yung drain sa CTT and you did open thoracotomy, so you must identify kung asan banda yung baka may vascular injury. So for example, for great vessels, simple lacerations, we can do aortography. So raphy, it means simple repair lang, simple suture repair of the lacerated vessels. For posterior aortic injuries, for complex ascending or transverse injuries, or those requiring interposition graft, kailangan tayo mag-cardiopulmonary bypass para mas control natin yung field, hindi madugo. Mas mamamanipulate natin yung vessels, mas ma-dissect natin yung vessels ng maayos, and we can properly apply your artificial PTFE graft. For innominate artery, we can do bypass exclusion techniques. For descending blunt aortic injury, to prevent aortic rupture, we can give esmolol to maintain an SBP of less than 100 and maintain a heart rate of less than 100 per minute. And we can do endovascular stenting to bypass the aortic artery injury. For chest injuries naman, meron tayong blunt and penetrating. So for blunt cardiac injury, we must monitor for dysrhythmias via telemetry. And yung pinaka-importante na diagnostic modality for assessing chest injuries that can be done immediately, that can and it is mostly available sa kahit anong centers, is your cardiac ultrasound. So sa cardiac ultrasound, makikita mo kung may impending pericardial diffusion. You can check for the function of your valves, or the check for the, makikita mo din kung proper yung contractility ng heart mo. So next, for penetrating cardiac injury, we must control hemorrhage. So if you're suspecting a cardiac injury, the next step is to do open repair. So we do thoracotomy. Yeah. Next, moving on to your trachea, bronchi, and lung parenchyma. For your pneumothorax, as I mentioned last night, your immediate management for pneumothorax is needling middling thoracotomy. Yun ba, middling. Sa second ICS, mid-clavicular line. But the definitive management is your tube thoracostomy, which can also be done for your massive hemothorax. For your bronchovenous fistula, chest CT scan with contrast must be done to identify the injury. We must properly control major air leak. So, pag may major air leak, it means may communication between your tracheobronchial tree and your pleural space. And you can see persistent pa rin yung bubbling ng chest tube, closed tube thoracostomy mo despite prolonged placement. So, kailangan mong magpa bronchoscopy to identify the site of the injury. And you can also do chest CT scan para makita yung kung saan yung break sa tracheobronchial tree so that you can do primary repair. So CTT again will not suffice. For lung parenchymas that are no longer viable, you can do resection or pulmonary tractotomy. Pulmonary tractotomy is done parang pag may lung parenchymal injury, parang ini-explore mo further yung lung parenchyma and identify major bleeders or bronchioles that are open. So nilalagay mo to prevent communication between your tracheobronchial tree and your pleural space. And we also identify bleeders to prevent further accumulation of your hemothorax. Next, for your post-traumatic pulmonary pseudocyst or your pneumatocyst, you must do aggressive pain management and pulmonary toilet by your chest tube. And we must do serial chest X-ray or chest CT scan if persistent in fever or leukocytosis. Kasi baka yung pneumatocyst or pseudocyst mo na-convert to an abscess formation or empyema. So it needs to be evacuated. Yung evacuation is CT guided. So you drain the abscess collection via a pigtail catheter. For empyema, so empyema is an umbrella term that for abscess collection sa pleural cavity, it can be secondary to infection pero sa trauma, it is usually caused by retained hemothorax. So hindi ma-evacuate na hemothorax na persists for several weeks. It may convert to empyema. And if empyema, if not drained, nag-solidify or naging loculated. So the management then is to do either VATS or video-assisted thoracostomy, or you can do open thoracotomy to properly evacuate the empyema and to do decortication. Decortication, yun yung process ng parang yung empyema kasi or abscess collection or pleural effusion sa lung caused by infection, parang kinukoat niya yan yung lung ng parang film, fibrinopurulent film that causes or prevents the lung from expanding. So yun yung nangyayari, parang trapped lang yung tawag. So pag meron ng ganun, kahit maglagay ka ng chest tube, hindi mag-expand yung lung mo. So you need to remove that. Yun yung process ng mental block. Decortication, sorry. Yan yung process ng decortication. So tinatanggal yan, parang pinipeel off mo yan na fibrinopurulent coating sa lung, either using your VATS or open thoracotomy. Next naman, we have your digestive tract, your esophagus. For your esophagus, if there's only minor injuries, may lacerations lang, or hindi completely transected, a primarily single layer end-to-end anastomosis can be done after the bridma. So kung asan yung injury, tinatanggal lang, i-resect lang, then end-to-end, dinidugtong lang with a single layer anastomosis repair. But if there's perforation at the gastroesophageal junction, missing duplication is done. For distal destructive injuries naman, all the necrotic or non-viable tissues are resected. So what's left, yung distal esophagus mo and possible yung distal na stomach mo, yun yung ina-astomose. Or yung ginagawa natin is gastric pull-up. So inaakyat natin, free natin yung stomach and inaakyat sa chest cavity to be anastomosed to your esophagus. For small esophageal injuries, we can do stenting. Stenting because small esophageal injuries may mga ulcerations, lalo na pag caustic injury, ulcerations, scarring, it can cause stenosis. So to prevent that, we can do initial stenting of the esophageal tract. For large destructive injuries, so lalo na pag unstable yung patient, if a large segment of the esophagus or upper stomach is involved and unstable yung patient, hindi wag kang mag-push to do primary repair because aside from it's going to be technically difficult and will take a long time to do. Kailangan mo ng resources, blood, etc. That's not available at the moment of your operation. So your immediate plan is i-divert lang muna. Divert lang muna yung esophagus para may drainage and stabilize the patient. Insert a gastrostomy tube for feeding. And once stable na yung patient, saka may balik sa or for definitive repair. Next, for chest wall and diaphragm, yung most common chest wall injuries are your rib fractures and your laceration of intercostal vessels. So, usually nangyayari to sa blunt chest trauma. And most of the time, pag chest wall injury, parang conservative naman. Rarely yung operative intervention. So yung ginagawa lang natin is pain control, pulmonary, toilet, via your chest closed tube thoracostomy. So you're anticipating kasi pag may rib fracture or may chest wall contusion, parang high velocity na blunt chest trauma. Lalo na pag may physical exam ka na possible pneumo or hemothorax, kailangan mo ng pulmonary toilet via your CPT and your ventilatory management. Lalo na pag in-pain yung patient, hindi yan makaventilate na maayos. Kailangan ng adequate pain control. And lalo na pag may flail chest ka, nasa Schwartz, kailangan, most of the time yung iba, kailangan ng positive pressure ventilation. So these are the indications for operative treatment of thoracic injuries. So ito yung mention ko earlier. Sa Schwartz, dinivide pala nila for you must do open thoracotomy if yung initial drain mo is 1,000 ml for penetrating or 1,000 ml for blunt. So pag may patient ka na na-receive or may tanong sa question na yung initial drain is more than 1 liter or more than 1.5 liter pag blunt, hindi ka na magko-conservative management. So kailangan mo nang buksan yan to do exploration. And as I mentioned earlier, pag more than 200 ml for the next 3 consecutive hours, kailangan mo nang buksan. Yung mention ko rin kahapon, pag hemothorax, despite naglagay ka na ng multiple chest tubes, hindi pa rin na-resolve yung hemothorax. Kailangan mo nang buksan. If with pericardial tamponade, you need to drain it. If with cardiac herniation, kailangan mo i-open din. If with massive air leak from any bronchopleural fistula. If with you have massive bronchial injury, if you open esophageal perforation, air embolism, you need to do immediate operative management. Next, for diaphragmatic injury. So if you have diaphragmatic injury, you are expecting the possible meron thoraco-abdominal injury. Okay? So pag may diaphragmatic injury ka, most likely may chest yan at abdominal injury. So yung ginagawa yung iba, pag may thoracoabdominal injury, you do a laparotomy incision. So you open the abdomen. And you also do a thoracotomy incision. You open the chest to check for any injuries sa chest cavity. For blunt diaphragmatic injury, usually the injuries are linear and the injuries usually are large. For penetrating naman, this variable in size depends on the agent na ginagamit. So mas destructive actually yung blunt abdominal injury. Yung ginagawa pag may blunt abdominal injury and you're considering a possible diaphragmatic injury, you must do first an abdominal approach to check for any visceral injury. So yung most common injured areas doon, yung malapit sa diaphragm, your liver, spleen, your stomach, pwede din sa may retroperitoneum, your pancreas, your duodenum, your small bowel, pwede mag-herniate through sa diaphragmatic defect. So, intra-abdominally, i-repair mo kung ano yung visceral injury, kung ano yung nakita mong visceral injury. Kung may liver injury, you must repair it. Kung may colonic injury, you must repair it. Then, hanapin mo yung diaphragmatic injury, i-debride mo. Pwede kang kung hindi naman penetrating injury, kumbaga hindi nag-through and through papunta sa chest wall, pag nag-x-ray ka or CT scan, walang chest injury, gumagawa ka ng pleural lavage. So, i-flush mo through your diaphragm papunta sa chest cavity sa pleural space, flush it with an SS to evacuate any blood or gastric contents or small bowel contents, repair your diaphragm, and insert a chest tube. Next naman, we have your abdominal injuries. So for abdominal injuries, for your liver, first we have your liver and extrahepatic biliary duct injuries. So for we do non-operative management pag minor injuries lang. So pag grade 1 or grade 2 liver splenic injury, hindi naman yan right then and there operahan agad. So yung iba, nagpe-present lang with radiological finding lang of the injury, pero soft abdomen, stable yung VS, hindi decreasing yung CBC niya, may serial na monitoring, hindi naman nag-decrease significantly yung CBC. So we do conservative management lang. Monitor the patient, complete bed rest. But for grade 2 or yung iba, grade 3 and above, we do hemodynamic monitoring. So we monitor your serum hemoglobin, usually Q6, serial abdominal examination if the patient may present later on with signs of peritonitis. So pag decreasing yung trend ng hemoglobin, then nagpe-peritonitis yung patient, nag-deteriorate. So kailangan buksan, kailangan operahan. But in other centers, we can do angioembolization or angiography or ERCP para to treat those grade 2 injuries na sa ating center binubuksan na natin. So ini-embolize lang nila yung bleeding vessels. So as mentioned here, pag solid organs kasi, yung presentation nila is hemorrhagic shock, is massive bleeding, pag abdominal trauma. So pag hollow viscous, your small bowel, your stomach, your urinary bladder, your colon, pag may rupture injury, your presentation sa patient is usually septic and may frank peritonitis and guarding. Pero pag may solid organ injury ka, spleen or stomach, yung presentation talaga ng patient is nagsashock yan, nag-hypotension, nagtataki, papibral conjunctiva, and sa serial monitoring mo, decreasing yung count. So more on bleeding talaga pag solid organs. So if higher grade yung injury, emergent laparotomy is indicated. Okay? Pag liver, extrahepatic biliary block, or splenic injury, the goal is to arrest hemorrhage. So what we do is we do perihepatic packing. So pinapalibutan yan yung liver ng, ng operative sponge or lock pack to initially control the hemorrhage. At the same time, hinahanap mo kung saan yung bleeding vessels in an attempt to ligate the bleeding vessel. Aside from that, if hindi makontrol, we can do your Pringle maneuver. So your Pringle maneuver, kinaklamp mo yung hepatoduodenal ligament kasi andun yung hepatic artery and portal vein. Tas while clamping, so lilimit mo yung blood flow to your liver para mas maganda yung visualization mo ng injury. Hindi makakontrol mo ng bleeding while doing repair. So for minor lacerations, so minor liver lacerations, so mga grade 2, you can do suture lang. You primary repair lang yung injury. You can do running sutures lang. Pero pag deep laceration, horizontal mattress yung ginagamit. For translobar penetrating, we can do tamponade with a Foley catheter or balloon occlusion. So pag malalim masyado yung injury, nilalagyan ng balloon catheter, ini-inflate sa loob to control the bleeding. Or in other centers, we can do angio-embolization. So CT scan, angiography, you locate the bleeding vessel and you embolize. For a gallbladder injury, cholecystectomy lang. For extrahepatic bile duct, we can do, so ano yung extrahepatic bile duct mo? So andun yung common hepatic, your cystic, and yung common bile duct. So yun yung extrahepatic bile duct mo. So kailangan nyo i-review yung anatomy, okay? So for extrahepatic bile duct, pag small laceration lang, like sa common hepatic or common bile duct, we can do a T-tube insertion after repair. So ano yung T-tube? Yung T-tube, it's like parang a way to divert bile palabas sa katawan. So yung parang naka-tube lang yan, naka-attach, naka-insert sa CBD, common bile duct, and naka-divert papunta sa palabas sa abdomen. Yung gamit nun is you're anticipating kasi na may injury kasi yung common bile duct and you did repair. So after that, you're anticipating na possibly magkaroon ng stricture or magkaroon ng obstruction. So pag magkaroon ng obstruction, the bile will not pass from your liver, bile duct to your colon. So kakaroon ka ng obstructive jaundice afterwards. So yung ginagawa natin is parang as a means na rin to stent the bile duct and to divert the bile palabas lang muna sa katawan while the CBD that you repaired is healing. Other repair we can do is your Roux-en-Y choledochoryginostomy. So pag extensive yung injury, we can connect your common bile duct to your jejunum directly. Okay? Lalo na pag transected. Okay. Okay, next, we have your splenic injuries. So for splenic injuries, yung grading nila, same, grades 1, more or less same lang sa liver injuries. So i-take note na lang nyo sa charts, basahin nyo lang yung grading. Pero for grades 1 or grades 2, splenic injury, if the patient, importante, if the patient is stable, if your physical exam is unremarkable, if your serial laboratory examination, especially your hemoglobin and hematocrit is unremarkable, we can do conservative management. So we can observe lang the patient. If grade 3 or higher in high-end centers, we can do angioembolization. So yun nga, angiogram, hanapin yung bleeding vessels and embolize. Pag severe injuries naman, grades 3 to 5, we can do operative intervention. So exploratory laparotomy, midline abdominal incision, and we can repair the spleen if grades 1 or 2. If grades 3, masyadong extensive yung injury, we can do partial splenectomy, kunin lang yung non-viable segment ng spleen. If grades 4 or 5, we can do total talaga. Remove the spleen entirely. So for splenectomy patients, kailangan na after 2 weeks, kailangan silang mabigyan ng vaccine and ng pneumococcal because these patients are at high risk for OPSI, for splenectomy infections, because di ba yung gamit ng spleen natin is they're part of your immune response for capsulated bacteria. So pag tinanggal mo yan, you're prone to having gonococcal, pneumococcal, and Neisseria infections. So meningococcal pala. So yun. So kailangan ma-vaccinate sila after 2 weeks. Okay? So bakit after 2 weeks? Kasi within 2 weeks post-op, mag-recover pa yan kasi yung patient. So hindi sila pwede mabigyan ng vaccine. Baka depressed pa kasi yung immune system nila that time. So post-splenectomy, there's yung parang expected natin, there's increase in platelet and WBC. And if there's increase in WBC until post-op day 5, mataas pa rin, 15,000, or you're possible magkaroon ka ng infection, pwede sa subclinic abscess or other sources of infection that needs to be treated. Okay? Pag subclinic abscess or complication nung splenectomy mo, the management is first visualization kung asan yung abscess via ultrasound or CT scan, and you do drainage, percutaneous drainage. So through the skin lang, pigtail catheter, usually hindi naman yan binubuksan. Okay, next we have your stomach and small intestine. So, actually sa lahat ng abdominal injuries, nasa Schwartz lang yan, or if you want to read further, merong kaming libro on trauma, Matox. Lahat yan, may grading yan. So, same for spleen and liver, may grading din sa stomach and small intestine injuries. May table yan sa Schwartz. So, pwede niyong basahin, familiarize yourself. For gastric injuries, yung ginagawa natin, if grades 1, grades 1, 2, or 3 na gastric injury, we can do primary repair. So, yung repair ng gastric injury, same lang. You can do a single or double layer na repair using a absorbable suture or stapler. For destructive injuries, grades 4 or 5, we need to totally remove the non-viable or necrotic stomach. Okay? So, yung ginagawa natin is partial gastrectomy na. Or we can do, if ganun talaga ka-severe, a total gastrectomy na. So, after gastrectomy, the one that is left, yung antrum, or kinoconnect lang natin we can do a Billroth 1 procedure. So, after distal gastrectomy, tinatanggal yung pylorus. Yung natitira, kinoconnect lang kung Billroth 1 to your duodenum para may continuity na naman. Okay? Billroth 1. So, Billroth 1, gastroduodenostomy yan. Stomach to your duodenum. Billroth 2, stomach to your jejunum. Pero sa gastric injuries, depending din sa viability ng duodenum, pag viable yung duodenum, tapos severe gastric injury, 4 or 5, we can do Billroth 1, so anastomose the remaining stomach to your duodenum. Pero kung hindi viable yung duodenum, we can use your jejunum instead. For small intestine injuries, so may grading in yan, grades 1, 2, 3, grade 1, may mga contusion lang, grade 2, less than 50 centimeters of the diameter, grade 3, more than 50, or grade 4, completely transected or devascularized. So, depending on the injury, kung ano yung gagawing management. If contusion lang, or less than 50% yung laceration, you can do primary repair. Kung asan lang yung injury, doon lang tatahiin. Pag medyo extensive yung injuries, more than 50 or completely transected, devascularized, you can resect the segment and anastomose end-to-end yung affected bowel. Okay? Yeah. Pag mesenteric injuries, anong ibig sabihin? So, yung mesentery mismo or yung alam mo nyo naman kung ano yung mesentery, di ba? Kumbaga, andun yung blood supply ng small bowel. Pag andun yung injuries, so you're expecting na wala nang blood supply distal to that your small bowel. So, ang ginagawa natin is we do resection. So, hindi ka na magtatahi lang ng repair. Hindi mo lang, hindi minimal yung repair mo. So, extensive dapat. Remove all the necrotic and viable tissue and resect and anastomose the bowel that is viable. So, next, we will duodenum. For minor duodenal injuries, hematoma. Pag hematoma lang, usually, majority of duodenal injuries are caused by blunt abdominal trauma. Yung duodenum kasi natin, nasa retroperitoneum yan. So, kung yung nasa retroperitoneum is behind, di ba? Yung peritoneum, nasa likod lang yan is your vertebra. So, yung blunt abdominal trauma, minsan, your duodenum, nasa sandwich siya between your impact and your vertebra. So, naiipit yung duodenum and it can cause laceration or destructive injuries. Yung iba naman, gunshot wound and penetrating stab wound, yun nga, because of the weapon na ginagamit. Pero kung hematoma lang, conservative management lang. So, NGT lang and parenteral nutrition. So, NPO lang muna, hindi lang muna papakainin for at least 5 to 7 days. Wait for the duodenum to heal. At the same time, decompress the stomach para walang po dumadaan sa duodenum. And at the same time, magbigay lang muna ng parenteral nutrition. Okay? But if extensive yung injury, lalo na pag combined duodenal and pancreatic injuries, kailangan ng operative exploration to repair, to reconstruct the continuity of your GI tract and the continuity of your duodenal, of your pancreatic duct. For pancreatic contusions, pag grade 1 lang, minor injuries lang, again, conservative lang. Yung iba ginagawa non-operative NPO lang, tapos NGT, parenteral nutrition. Pag may proximal and distal pancreatic injuries, you can do insert lang a drain, closed suction drain. Tapos, parang we can do observe lang and wait for the injury to heal itself. Pag may disruption talaga, kailangan ng reconstruction. So we can do a distal pancreatectomy or we can do distal pancreatectomy. So yun. Pag extensive pancreatic injury, you can do your People's procedure. So it's pancreatic o duodenectomy. Next, for colon and rectal injuries. For colonic injuries, same lang yung grading sa small bowel. So grade 1, contusion, 2 and 3, less than 50 or more than 50% of the circumference. Pag 4, total transection, and 5 if may tissue loss. So if for grades 1, grade 2, pwede primary repair lang. So suture lang, a 2-layer repair, Connell and Limbert. So you can read on that. Basta 2-layer repair lang. Pag grades 3 or 4, pag extensive injury, we don't repair the colon, primary repair. We resect and anastomose the colonic segment. But take note, in all small bowel and large bowel injuries, pag toxic talaga yung patient, if the patient is unstable, may massive na GI spillage, may massive na bleeding, may multiple blood transfusions ka ng intra-op, yung the process of anastomosing kasi it takes time and it requires that the patient has a adequate nutritional status. So pag toxic yung patient, instead of anastomosing, inalabas na lang natin. We do colostomy. So inalabas na lang natin yung bowel para mabilis. The fastest OR possible. Yun. We do your end colostomy pag toxic yung patients, pag devastating injuries, or we can do primary repair of your colonic injuries, and proximal to that, we can divert your ileostomy. So, sa ileostomy lang muna lalabas yung feces para yung distal mo na colon mag-heal while mag-heal yung tinahi mo. Yun. Hindi na-mention dito sa PowerPoint, yung rectal injuries naman, may grading din yung rectal injuries and yung management depende kung intra or extraperitoneal yung rectal injury. Okay? So, alam naman natin yung rectum, yung proximal, 2/3 ay intraperitoneal, yung distal is extraperitoneal. Pag extraperitoneal na rectal injury, yung management usually is diversion. So, linalabas lang muna yung bowel, proximal to the injury. Pag intraperitoneal, we can do repair. Next, abdominal and pelvic vasculature. So, for penetrating, we can identify the pag penetrating tapos patient is hypotensive and unstable. We can do emergent laparotomy, exploratory laparotomy, identify the vascular injury, and do primary repair. If blunt, yung most commonly involved vessels are your renal vasculature and occasionally your abdominal aorta. So we do immediate XLAP. We identify the bleeding vessel. If extensive yung injury, we can use an interposition graft. Okay? Here, ito yung superior mesenteric artery. Superior mesenteric artery, pag na-injure yan, so mawawala ng blood supply yung small bowel. So the patient may present with hypotension and the patient may present with abdominal pain, extreme abdominal pain, tapos with direct and rebound tenderness in all quadrants. For pelvic vascular injury, we can do your Pruvi Inahara shunt, or we temporarily shunt the vascular injury. So, i-divert na muna natin yung blood flow. And we can also do interposition grafting if extensive yung vascular injury, so hindi natin ma-anastomose end-to-end. We can do a PTFE graft. Next, we move on to your genitourinary tract injuries. So for parenchymal renal injuries, for your kidney injuries, pag grades 1 or 2 or the patient is hemodynamically stable, PE is unremarkable or hindi decreasing yung serial hemoglobin hematocrit and hindi persistent yung hematuria, we can do conservative management or we can do observation lang. Okay? Or aside from that, we can also do angioembolization. But because yun nga, as sabi dito, 90% of blunt renal injuries are treated non-operatively. Okay? But if decreasing yung hemoglobin and unstable yung patient, kailangan na natin buksan para mahanap. Baka kasi may transaction sa hilum, so andun yung renal artery and vein that needs to be repaired. So other injuries, or injuries to the ureters and bladder injuries. So ureteral injuries, pag lalo na pag penetrating, so there's complete transection, or if blunt injuries or destructive injuries, the ureteral injuries needs to be repaired. So pwede mag end-to-end anastomosis, or you can do stenting. For bladder injuries naman, if minor injuries lang, hematoma, or extra peritoneal, we can insert lang an FBC, polybrag catheter for drainage, and observe the patient. Pero pag intraperitoneal and grade 4, So, may malaki na defect, more than 2 centimeters yung defect sa intraperitoneal posterior wall ng bladder. So, lalabas yun yung ihi, magsispill out sa abdominal cavity, and it can cause urinoma. So the patient may present with surgical abdomen. So it needs to be operated upon, bubuksan yan, and kailangan yan i-repair yung bladder. Two-layer din yan, two-layer na observable. And some consultants, after repairing the bladder, lalo na pag extensive, nag-insert din sila ng cystostomy tube. So, cystostomy tube, parang catheter yan from your bladder directly palabas sa abdominal cavity for drainage, para hindi mag-increase yung pressure sa loob ng bladder, para properly mag-heal yung repair. And next, we move on to female reproductive tract injuries. So, yun, same, like it's either penetrating or blunt. So, for blunt injuries, you may suspect for genital tract injury if may pelvic fracture, genitourinary, actually, if may pelvic fracture. For penetrating injuries to the vagina, uterus, fallopian tube, and ovaries, you may need to do repair via, if nasa labas lang naman, you can do primary repair lang. If may injury talaga sa loob, if the patient may present later on with infection, with sepsis, with pelvic inflammatory disease because the non-viable adnexa or may uterine injury, kailangan i-open, kailangan i-drain yung abscess, and we do debridement repair. So if according to Schwartz, if may injury sa fallopian tube or ovary, we can do salpingo-oophorectomy. Next, for extremity injuries, kailangan ng immediate stabilization if may fracture. So if ma-identify ka ng fracture by your physical examination or X-ray, it needs to be stabilized via either dalawa, you do a cast or you do traction. Because if hindi immobile yung fracture, it can do further injury, lalo ng vascular injury. If the fracture naman is associated with a vascular injury, lalo na pag sa lower limb, upper and lower limb, pag nasa may joint, malapit sa popliteal or malapit sa elbow, malapit sa axilla, andun yung popliteal artery, your posterior anterior tibial, or andun yung brachial artery mo, pag may dislocation dyan or fracture, and the patient presents with hard signs of vascular injury, or the patient may present with compartment syndrome, so yung mga paresthesia, pallor, it needs to be repaired. Okay, so kailangan ng immediate exploration, hanapin yung transected vessel, and it needs to be repaired. At the same time, i-repair din yung, i-stabilize and i-repair din yung fracture or dislocation. So ito yung mention ko, yung compartment syndrome. The causes are arterial hemorrhage into a compartment, crush injuries, or reperfusion injury. What is reperfusion injury? So yung reperfusion injury, nangyayari to pag may vessel occlusion ka, may vessel occlusion, then suddenly i-relieve mo yung occlusion na yon. So, pwedeng i-anastomose mo with transected vessel, then i-re-anastomose mo or nag-thrombolysis ka because of the prolonged occlusion na yon, yung areas na previously ischemic, magkakaroon ng blood flow papunta sa normal part of the limb. So, yung mga oxygen radicals, yung mga inflammatory substances dun sa ischemic limb magsa-spread out papunta sa normal limb and sa systemic circulation, causing further injury. So, yun yung reperfusion. Yung symptoms ng compartment syndrome, minention ko gabi, is due to injury to your neurovascular structures. So, yun, pain, pallor, poikilothermia, paresthesia, paralysis, and pulse deficit. The management for compartment syndrome is fasciotomy to relieve your compartment pressure. Okay? So, if more than 6 hours, yun yung leeway natin. Dapat as much as possible, ma-relieve yung pressure before 6 hours. If 30 millimeters mercury, yung yung pressure that may cause your compartment syndrome. So ito yung ginagawa natin. So for your compartment syndrome, your immediate management is fasciotomy. So ito yung ginagawa. Rini-relieve natin or tinatransect natin yung fascia para ma-relieve yung pressure sa loob and ma-relieve yung compression sa neurovascular bundle sa gitna. Next topic, surgical intensive care management. For toxic patients, toxic trauma, or critically ill patients, acute resuscitation is done for the first 12 to 24 hours. So what are the important points to consider? We must optimize tissue perfusion, ensure normal hernia, restore your coagulation status. So yung nakapansin mo, yung management nila is the ones that are preventing your deadly triad, di ba? Your coagulopathy, hypothermia, and acidosis. Okay, yung deadly triad. And your hemoglobin must be maintained at least 10 grams per deciliter to properly oxygenate or perfuse your tissues. Yung initial...
Hold. Hold.
So yun, yung initial na management natin is volume loading. So we infuse crystalloid. But if the patient is unresponsive, after volume loading, we can start your pressors, your inotropes or vasopressors. And the patient is having hemorrhagic shock, other than infusing your crystalloids, we can start your massive transfusion protocol. So we transfuse blood instead. This is your post-injury resuscitation. If resuscitate mo yung patient, na-stabilize mo na, you can do further imaging. Okay, so CT scan, CT angiogram, and after stabilizing, after doing your imaging, if the patient, yung ginawa nyo lang sa OR or sa ER is to, like for example, yung open thoracotomy, ER thoracotomy, ino-open lang, you do manual compression of the heart, hinahanap lang yung bleeding structures, then stable na yung patient, we can return the patient to the OR after yung damage control na ginawa nyo and do definitive repair. So this is the things that yung endpoints natin that needs to be met. The core temperature must be above 35, base deficit is less than 6, and normal in coagulation indices. Again, preventing your lethal triad. For post-op wounds naman, we can do post-op wounds. For trauma wounds, external wounds, you can do initial debridement. Initial debridement at the emergency room, pag may mga lacerations, mga avulsions, tissue loss, initial debridement, and so on, maintain natin yung wet to dry dressing and vacuum device if available. For middle laparotomy wounds, abdominal incisions, you must inspect the wounds 48 hours post-op to check for surgical site infections. So what are the signs of your surgical site infection or infection in general? The patient may present with fever, erythema, pain, and discharge on the post-op site. So ito yung abdominal compartment syndrome. Your abdominal compartment syndrome usually happens pag after OR, hindi matus yung bowel. So, pinilit mong isara with tension. So, yung intra-abdominal pressure mo mataas. Okay? So, hindi lax yung abdominal wall. Tapos, mataas yung pressure sa loob because of the edema, because of the fluid collection. So, it could cause compression here of your kidneys, thereby decreasing blood flow. It can decrease venous return because it's compressing your large vessels, your vena cava. And it can increase your intrathoracic pressure because of upward displacement of your diaphragm. So these are the effects, okay? So the way to measure your abdominal compartment syndrome is via your bladder pressure. So ito, yung grading ng abdominal compartment syndrome, grades 1, 2, 3, and 4. So pag grades 2, 3, and 4, or grades 3 and 4 rather, the abdominal compartment syndrome must be released. So kailangan ulit i-open yung abdomen, explore lang ulit, release lang muna yung abdominal cavity, naka-open lang muna siya, dinalagyan lang muna ng protection, ng film or vacuum device para mabigyan ng panahon yung small bowel, yung edema mag-decrease or yung fluid collection may evacuate. After that, pag mag-decrease na yung abdominal pressure, saka na i-close. Next, we have your special population. So, mas na-mention naman yung ng mga physiologic effects, di ba? Ay ubigay ng lecture. Okay? So, for pregnant patients, there are other things that is to be considered when dealing with them at the emergency room for trauma patients. So, hindi sila parehas sa normal na adult. So, yun. These are the things that needs to be considered. Iba yung cardiovascular, pulmonary, hematopoietic ang function nila compared to the regular adult. And because of that, mas aggressive yung resuscitation natin. Kailangan yung early detection of your injury, okay? And kailangan din careful din yung management, okay? Kailangan careful yung management, careful yung manipulation ng abdomen. Hindi tayo x-ray ng x-ray or CT scan agad. We must ask the patient kung kailan yung LMP, kailangan i-pregnancy test, or if kailan yung EUG, then kailangan din i-refer if nasa ER, so kailangan din i-refer na sa OB-GYN to check also for the viability of the fetus. So these are the physiologic changes. Your ELP is normal, your albumin decreases, your BUN and creatinine decreases, and upon imaging, we have your hydronephrosis and hydroureter because of your enlarging uterus. And your hematologic parameters, 11 grams per deciliter pa lang, parang it's already a sign of anemia. There's moderate leukocytosis and there's a relatively hypercoagulable state. For pregnant patients, supplemental oxygen is always warranted because pregnant patients now desaturate more rapidly, particularly in supine position and during intubation. We must do aggressive fluid resuscitation, and we must place the patient in a left lateral decubitus position. To avoid cable compression and increased preload, increased blood flow to your heart. So thoracostomy tube insertion, it will not follow yung fourth or fifth ICS because your diaphragm is elevated. So baka ka mag-thoraco abdominal injury o baka ka diaphragmatic injury. And sa FAST, aside from assessing for fluid collection, we can also assess the fetal status. And for DPL, it should be performed in a supraumbilical site with catheter directed upward, hindi directed papunta sa baba because you might injure the ureter or the uterus and the fetus inside. So for radiograph, so it is important to shield the pelvis. So meron tayong lead aprons. The max dose is less than 5 rad. So yung ginagawa natin, as much as possible, hindi natin in-expose yung pregnant sa X-ray radiation. So we can do ultrasound instead, or if kailangan, we must protect the abdomen. For the assessment, fetal heart rate is the most valuable information regarding fetal viability. Okay? The normal range is 120 to 160 beats per minute. For maternal-fetal management, the indications for immediate cesarean section, if the mother is in maternal shock or impending death, or there's signs of possible uterine injury. So there's massive vaginal bleeding, patient is in shock, unstable, anemic, and if the fetus is delivered within 5 minutes, the survival is greater. So it's estimated to be more than 70%. So after stabilizing the mother, so we move on to our secondary survey. So these are things to ask sa secondary survey. Pregnancy-induced hypertension, history of DM, CHD, if he had any preterm labor, or ask for fetal movement. So yun, we must ask if may strong contractions, kasi baka true labor na. We must ask for vaginal bleeding, baka kasi nag-abruptio placenta or placenta previa. Or we must ask if the patient already had or experienced ruptured amniotic sac. So vast majorities of injuries are treated similarly whether the patient is pregnant or not. So yung specific considerations natin is pelvic fracture because as mentioned ko dati, fracturing pelvis, estimated blood loss natin is 2,000. So there's risk of torrential hemorrhage and shock. And if shock, the fetus kasi is very much sensitive to hypoxia. So it may cause fetal demise. Penetrating injury naman, malaking surface area ng uterus by third trimester. So malaking chance na ma-injury din yung fetus. So for monitoring, patients should be monitored in the hospital for at least 24 hours. So for symptomatic, these are the things to watch out for. And if these are the things to watch out for that are high risk for fetal loss. If vehicle injection is involved, if the patient presents with maternal tachycardia, and if the patient reaches this gestational period is more than 35 weeks, and if the patient also has prior history of assault. Sorry. Next naman sa geriatric patients. So these are the physiologic effects of aging. So cardiovascular, pulmonary, intracranial, cardiovascular. Majority of geriatric patients has atherosclerotic diseases. So there's progressive loss of elasticity ng myocardium, decreased na yung stroke volume, decreased na yung cardiac output. There's calcifications na atherosclerosis, major and peripheral vasculature. Pulmonary na, there's loss of compliance, so decreased na yung tidal volume. Yung intracranial naman, there's loss of cerebral volume. So pag there's loss of cerebral volume, mas mahaba na yung bridging veins. So for geriatric patients, there's increased risk for tearing of your bridging veins, kaya mas prone sila to have subdural hematoma. Kaya yung mga head injuries ng geriatric patients, as much as possible, nagsi-CT scan tayo to rule out subdural hemorrhage. So here, rib fractures is the most common sequelae of blunt thoracic trauma. So for rib fractures, pain management, and others have concomitant pneumo and hemothorax. So we manage that as well. So for geriatric patients, head injury has 2 times mortality, and it doubles after the age of 55 because of what I've explained earlier. Mas maliit na yung utak nila kasi nag-atrophy, so mas mahaba yung veins, bridging veins. So pag mabilis yung velocity ng head during an accident, there's an increased risk for tearing ng mga veins na yun. So outcome predictor. So chronologic age is not the best predictor of outcome. The best predictor is your injury severity score. Next, your pediatric patients. So ito yung most common causes of injury for toddlers, fall, children, adolescents, and same as adults, parehas pa rin. Primary and secondary survey. Primary survey, your ABCDE. Maintain airway, check for problems breathing, circulation, check for injuries, cerebral or extracerebral, and check for exposure. If like for burn injuries, chemical ingestion, chemical injuries. For airway, the airway is smaller and more cephalad in position. So less than 10-year-old, the larynx is funnel shaped. The tongue is much larger in relation to the oropharynx. So mas mahirap yung intubation and iba yung ginagamit na laryngoscope. So yung ginagamit natin is yung Miller blade straight as compared yung Macintosh. Kung nakakita na kayo ng laryngoscope, iba yung pedia at iba yung adult na laryngoscope. Straight yung laryngoscope ng Miller, curve yung Macintosh. And cricothyroidotomy is contraindicated for less than 11 years old because of subglottic stenosis. So instead, immediate tracheostomy is done. Okay, so hindi ka nag-cricothyroidotomy for less than 11 years old na patients. So yun, oxygen consumption in infants and adults is twice that in adults. In infants and young children is twice that in adults. Placement of NGT may facilitate effective gas exchange to decompress the stomach. So for pediatric populations, kailangan alam yung weight ng patient because diyan yung kino-compute yung kung ilan yung ibibigay na fluid resuscitation kasi hindi tayo bigay lang ng ang fluid boluses, especially for pediatric patients. Okay, so the computation is 20 ml per kilogram of each crystalloid. If hindi siya nako-correct despite fluid resuscitation, it may be due to TBI or traumatic brain injury or hypovolemia from bleeding or shock or from neurogenic shock or cardiogenic shock. So, if persistent lagay-up na hypotensive, you must investigate kung ano yung source ng hypertension. For pediatricians, acute traumatic brain injury is the most common cause of death and disability in any pediatric age group. So, for extremes of age, for geriatrics and pediatricians, CT scan is indicated. Okay. Chest trauma. For chest trauma, for pneumothorax, less than 15%, observe lang. If more than 15%, we do tube decompression. So, pag upon receiving the patient toxic, so we can do needle thoracostomy. For hemothorax, this is the indication for open thoracotomy. So sa adult, diba, 1,000 penetrating, 1.5 equivalent. Sa bata, if 20% of the blood's volume is evacuated or 1 to 2 ml per kilogram per hour. So open thoracotomy is indicated. For abdominal trauma, same. We do fast to detect intra-abdominal fluid. And if the patient is stable, non-operative management tayo. So, usually pag mga grade 1, 2, or grade na clinic or labor injury, soft abdomen, stable patient, normal yung serial monitoring, observe lang. But it is contraindicated if the patient is deteriorating and unstable, okay? So, pag unstable yung patient, pag bumabagsak yung BP, bumabagsak yung hemoglobin, baka mas extensive na solid organ injury. So, you need operative intervention. You need to secure blood for transfusion. But in high-end centers, you can do embolization instead of operative intervention. That's all for trauma. Do you have any questions? Nayakan ni Dr. Adona, may dito ko nag-prepare ng exam Doon, direct sure kung saan niya gahatag. Pero hindi na daw ako nagpahala. Amot, bayan ako tiyab o pro-proctor, diri pa ko sure kung saan tiyo schedule. Okay. If you don't have any questions, that ends my lecture on trauma.
Thank you, Doc. Ma-screenshot po ako. Sige. So, first page. Second page. Third page. Okay, done na. Thank you.
Thank you po, Doc.
Thank you, Doc.
Doc.
Okay.
Thank you, Doc.
Doc.
Thank you po, Doc.